Thank you all for joining me today to talk about malaria diagnostics. I'm Dr. Bobby Pritt, and I am the chair of the Division of Clinical Microbiology at Mayo Clinic. I'm also the laboratory director for the Clinical Parasitology Laboratory, and my major areas of interest are the laboratory detection of parasitic infections and vector-borne diseases. So today we're going to talk about malaria. Before we begin, I will say that I have no financial relationships to disclose, and I won't be discussing anything off label or in investigational use. So, with that, let's dive right in. We'll level set with some basics about malaria. It's caused primarily by four species. Those are the four causes of human malaria: Plasmodium falciparum, Vivax, Malariae, and O. valley. Now, there is a zoonotic cause of malaria. In fact, there are several, but one that you've probably heard about is Plasmodium knowlesi. This is truly a zoonotic form of disease. It mostly infects monkeys, but humans can occasionally be infected with this species. We're going to be focusing on the top four. Regardless, this is a potentially deadly disease, particularly with Plasmodium falciparum infection, and so diagnosis should always be performed on a stat basis. So, how do we diagnose malaria? Well, there are different types. Microscopy is still the gold standard using traditional blood films, Giemsa stain traditionally. You could also do concentrated blood preparations. There are antigen detection methods, and those are increasingly used around the world. In fact, they've become one of the primary methods recommended by the World Health Organization in the control, elimination, and potentially eradication of malaria someday in the future. There's molecular amplification methods. They have a role, although they are more limited in their distribution. And then last but not least, there is serology. I mentioned it. It can be used for blood donor screening, epidemiologic studies. It has very little role in clinical diagnostics, and it is not useful for diagnosing acute disease. And that's because it takes several days for antibodies to become detectable. With malaria being potentially life-threatening, you can't wait to get a detectable immune response. You need to be able to diagnose the malaria rapidly. Now, if you want to read a paper that I wrote recently with my colleague Blaine Matheson called Update on Malaria Diagnostics and Test Utilization, the details are listed here. It has a nice chart and an algorithm, and the chart compares, the table compares all the different ways you can diagnose malaria. So check it out if you'd like more information. I'm going to cover the highlights today. So we'll start with the conventional gold standard blood films. What type of blood do we use when we're doing our gold standard blood films? Well, you could perform a capillary stick, so finger prick or ear, or more commonly today in a resource-rich setting in the United States, we're usually doing a venous blood draw, which then comes to the second question of which anticoagulant do you use? EDTA, the lavender or purple top tubes, are preferred. There's two different types of films that ideally are made and examined for each malaria smear. So there's a thick blood film and a thin blood film. Now, if we were in person, I'd be asking you these questions and waiting for your responses. Instead, you'll have to quiz yourself as we go through this. So, what is the purpose of each of these? We have the thick blood film, like its name implies it is a thick layer of blood. Therefore, it's very good for screening. It's more sensitive and you can easily detect parasites that are present. The thin blood film, on the other hand, is primarily used for species identification. Some people also use it for screening. You just need to know that you need to examine many more thin films to get the sensitivity of a single thick film. But the thin film, also by its nature of how the red blood cells are preserved, is very good for identifying species. Now, some of you may be thinking in your head, speciation, correct? Just a little public service announcement, a word about speciation. This is actually a widely overused word. Unfortunately, it's taught to us in medical school this way. It's incorrect, though, the way most of us use it. Speciation, as it is officially defined is the formation of a new species in the course of evolution. So if you had an island that was separated from the mainland and you had a species of bird that over time evolved into a new species, that would be considered a speciation event. But we do not perform speciation in the laboratory. So instead, you should say species identification. You could also say specification, although that would probably get you some odd looks. All right, now that we've talked about the different types of preparations, let's talk about the stain of our blood film. The Giemsa is the classic. You want to perform it at a pH of 7.2. That's best for defining important features such as stippling, Schaffner's dots, Mauer's clefts. And this is just a picture from my laboratory of our Giemsa stain. We make it up fresh every 8 hours. There's also a right Giemsa stain that's commonly used in the hematology lab. That's acceptable as well. It is not probably going to show you all of the same features. In particular, stippling and clefts may not be visible because it is a more acidic stain. So here's a nice example of Schaffner's dots in a case of Plasmodium vivax, and you can see the Schaffner's dots very clearly here. This is a different case with the right Giemsa stain, and the Schaffner's dots are missing. You can still make the diagnosis, but you just have one less helpful feature in making that diagnosis. There are also rapid stains. There's a stain called field stain, which is good for field use, rapid point of care testing. So let's talk a bit about our thick and thin film, since these are our gold standard tests. We'll start with the thick film, the most sensitive film because it's thick. It has the thickest layer of blood. It's made by placing 2 to 3 drops of blood on a slide and then letting it thoroughly dry. You do not fix it in methanol. And then when it is completely dry, it's placed inside into a bottle, a container of malaria stain. And the malaria stain has water in it. And the hypotonic nature of the stain means that the stain rushes inside of the red blood cells, the water, it bursts the red blood cells, and that releases all of the intracellular parasites. So now you have all the parasites free from the red blood cells, and all the red blood cells have been lysed. So you could very easily focus up and down through that thick layer of 2 to 3 drops of blood and identify even just a few parasites. That's why it's more sensitive. So we'll have my cartoon here of my slide with the blood film, and then all the red cells will be lysed. So on higher power, this is a view of a positive case with Plasmodium falciparum. You can see these larger areas, these larger cells are white blood cells. They tend not to lyse, but all the red cells are lysed. And here we have a very nice parasite, a very thin ring form of Plasmodium falciparum with the classic headphone form. You could also see other stages less commonly, but you can see schizons, late stage rings, merozoites, gametocytes, banana-shaped gametocytes or round gametocytes. So any of the stages you can see in a thin blood film, you can also see in a thick blood film. Tips for making a good thick film. Because it's so important for screening, you want to do it right. The goal is to make it as thick as possible while still being able to read newsprint through it. And I love this old image where it shows this really neat old newspaper clipping. And you can see this thick film. You could just read the newsprint through it. This actually happens to be a slide where you have the thin film and the thick film made on the same slide. When done right, it'll be about 20 to 30 cells thick. Now, some problems with the thick film. Because it's so thick, the blood will often fragment or just fall and just slide right off the slide if not properly dried. Some people will let it dry overnight. Now, obviously, that's a problem because this is your most sensitive film and you don't want to have to wait until the next day to review it. So we have some tips for improving the adherence that I think will be useful. First, your slides need to be clean. If you're reusing slides, that's not usually done in North America. And the slide must be completely dry before staining. And then something that we've been doing at Mayo Clinic for a very long time, decades, is we use a method called the scratch method, where we scratch the blood onto the slide. And we published on this and found, as we had observed for decades, that it virtually eliminates any of the sloughing of the thick blood film off of the slide. And therefore, it allows you to stain the slide as soon as it is dry, which could be 20 minutes. So it's really a nice practical method. Let me show you how it's done. We put a drop of blood on the slide, and this would be the carrier slide. And then we take a second slide and put the corner of that second slide down into the blood film. And just with gentle pressure, move it in a circular method to spread our thick blood film so that you have it spread out. And at the same time, you're scratching in microscopic grooves on the slide, which just gives it more surface area and the ability to adhere to the slide when it's then placed into the stain. So I would encourage you all to try it. It's very practical, very easy to do, doesn't take any special equipment, and it will allow you to review your thick film right away as soon as it's dry. Moving on to the thin film, this is made in the same manner as the hematology smear, what they do for peripheral blood films. It is fixed in methanol because you do not want those red blood cells to lyse. You want them to stay intact, and therefore you could see the parasites in situ inside of the red blood cells, and you can see the size of the infected red blood cell, which, as we'll discuss in a little bit, is an important feature. So again, with my little cartoon schematic, the blood is smeared in a thin film, and your result is that you could see intact red blood cells. There's a white blood cell. And then here we have our red blood cells with nice thin rings of Plasmodium falciparum inside of them. We'll talk about the different features of differentiating the species in a little bit. So here is a technologist who is making this thin film. She put that little drop of blood on the slide. She's now using a second slide, pulls back, lets the blood pool all the way along the edge of the slide, and then in one continuous motion, pushes the blood film out. So the end result will have this fine feathered edge. And this is important because this is the area where you're going to be examining the blood slide for potential parasites. Now, where you examine on the blood film is important. The ideal area would be towards the end of the feathered edge, not the very end, but just where the red blood cells are starting to touch, but there's not too much overlap. This happens to be a case of Plasmodium ovale, which you may know a third of the cells infected with Plasmodium ovale are oval shaped. It's how it got its name. And so you can see a nice oval shaped parasite here, and you can appreciate the morphology, the stippling, and a rather compact trophozoite here. Now, if you go too thin out into the feathered edge, the red cells lose their central pallor. They start molding to one another, and the cells ball up, and it's a little hard to see their actual size and shape. It's even worse if you go out into an area where it's too thick, because then everything looks smaller, it's overlapping. And I've seen many people miscall species because they're looking out in an area where it's just too thick to really examine the morphology. So don't make this mistake. It's a very common mistake. Make sure you're looking in the right area when you're trying to identify what parasite is present based on morphology. So now we're at that stage where we want to do a morphologic interpretation of numerous characteristics to determine which species is present. Now, in reality, we do this based on a simultaneous examination of numerous characteristics, such as the size of the infected red blood cell, the presence or absence of red blood cell stippling and inclusions, the different life cycle stages present, and an experienced observer can keep all of these things in his or her mind. So let's look at the CDC life cycle. We are talking specifically about the stages shown here that you see on a blood film. After the liver stage, merozoites, individual parasites released from a liver cell, will come and infect individual red blood cells. they first become an immature trophozoite, what we call a ring stage. And then this ring stage can go in two different directions. One direction is the ring becomes thicker and larger. It becomes a mature trophozoite. And then multiple nuclei through division start to appear. Once you start seeing multiple nuclei, that is the beginning of a schizont stage. And this is now a mature schizont with all of these little forms inside of them. They are all merozoites. When they rupture the red blood cell, the merozoites will go on and infect the next red blood cell. And the different species have different numbers of merozoites, so that can be a helpful diagnostic feature. Now, the other stage that this little immature ring stage can take is to become a gametocyte. That is the pre-sexual form. This is taken up by the mosquito and will then lead to sexual reproduction in the mosquito. This is not infectious to human red blood cells and will just remain in the blood until it's cleared by the patient or taken up by a mosquito. All of these different stages can be put into this nice little chart where you go with the different species, and then you can look at the early stages, late stages of the trophozoates, the schizonts, the gametocytes. But if you're going just by a chart like this, it can be very easy to go down the wrong path and put too much emphasis on one morphologic feature versus another. So let me show you a little trick, and that is this algorithm that I've created for identifying Plasmodium species. Now, some of those morphologic features are more important than others. Some are what I would call more definitive features, where others are more soft features, where they're indicative but not 100% specific to a certain species. So I'm going to tell you some of the more important hard features. One of them, which is very important and is a very good place to start, is the size of the infected red blood cell. And that is the size compared to its uninfected neighboring cells. So very quickly, you could split this into two groups. The ones that the infected cell is normal to small compared to the neighboring cells versus those that are in an enlarged red blood cell compared to the neighboring cells. Now, if you're in the normal to small category, you are either dealing with Plasmodium falciparum or Plasmodium malariae. And usually you don't see stippling, but occasionally you see Mauer's clefts with Plasmodium falciparum. And these are these few large reddish dots within the cytoplasm of the cell. They're fewer and larger than the stipples we will see with Plasmodium ovale and vivax. And those would be on this side of the algorithm. Plasmodium ovale or vivax are both in enlarged cells. And if you happen to see stippling, that is a great supportive feature. Now, of course, I'm presenting this as a generalization. I would never make a diagnosis based on just a single cell, except maybe on a board exam, because that's usually what they show you. However, in real life, you're going to be looking around and seeing multiple examples. And you want to ask yourself, what the general characteristics are. So with Plasmodium vivax and Plasmodium ovale, in general, the infected red blood cells are larger compared to the uninfected neighboring cells. Okay, now this is pretty good because we've just gone from 4 species down to 2. So you just cut your work in half, which is great. Now you use all the other features to differentiate and go down to the actual species level. So let's go through those one at a time, and we'll try to make it as easy as possible. So species-specific details. We'll start with Plasmodium falciparum. If this was a theater piece, this would be the villain of the piece. It is the most virulent. It infects all stages of red blood cells, and that allows you to get very high levels of parasitemia. Whereas the other human strains or species that cause malaria are limited to either old red blood cells or young red blood cells. Plasmodium falciparum is non-discriminatory. It infects all, and therefore you get those high levels of parasitemia, which could be very fatal very quickly. It also has the shortest incubation period, so it very quickly turns over and infects more and more red blood cells. Another reason why it's more virulent. Some other virulence factors that are important to note, though. There's a phenomenon called sequestration, where infected cells will marginate in the endothelium of capillaries, and another phenomenon called cytoadherence or rosetting, where the infected red blood cells will become sticky and they will stick to other red blood cells. So not only do you have infected cells sticking to the endothelial margins of your capillaries, but they're also sticking to other red blood cells. All in all, this just gums up the works. It ends up with sludging and hypoxia, and then you get some of those end organ manifestations like cerebral malaria. So let's look at some examples of that. First, let's look at this schematic that shows you how this works. So Plasmodium falciparum, the parasite inside the infected red blood cell, actually inserts its own antigens, this Plasmodium falciparum endothelial membrane protein 1, onto the outer membrane of the red blood cell, and then through receptor binding will bind to CD36 and other markers of the endothelium, and then you get that sequestration and the cytoadherence. So this is a capillary in the blood. You can see the capillary branching here. This is brain. So sorry, there's blood inside the capillary, but all of these individual red blood cells are infected with Plasmodium falciparum. And in fact, you're seeing this brown pigment. That is the hemozoin pigment. That's the breakdown product of the hemoglobin that's being digested by the parasite. So basically, this is filling up that whole capillary. Not a lot of good oxygenation happening there. Here is a cross section of a capillary, and a classic feature you see in the brain is this hemorrhage around the capillary, what we call a ring hemorrhage. So classic diagnostic histologic feature. And again, notice all the brown-black pigment. That's the hemozoin of the breakdown products of these parasitized cells. So let's go through these one at a time for Plasmodium falciparum. Here are all of the individual features. Now, in general, you just see the rings of the early trophozoite stages. That's because the late stage trophozoites and the schizonts are all sequestered in the peripheral blood. You also will occasionally see gametocytes in the peripheral blood, but for the most part, it's just going to be these very thin, delicate rings, about the third or less of the size of the red blood cell. And sometimes you see what are called headphone forms, where there's two chromatin dots. This isn't a great example, but it is one. You also see something called applique forms, where the parasite looks like it's been applied to the outside layer of the red blood cell. Here's another one. It's actually intracellular, but it looks like someone just stuck it or applied it to the outside. You could also get multiple rings within a single red blood cell. That's a soft feature. You could see that with other species as well. I've seen that with Plasmodium vivax several times. And then the banana-shaped gametocytes. And then another phenomenon occasionally seen is Mauer's clefts. It's not stippling. It's these dots here that are kind of reddish. They're a little bigger than stippling, and they're fewer in number. And so this is an example of Mauer's clefts in Plasmodium falciparum. Here are those beautiful banana-shaped gametocytes that we see with Plasmodium falciparum. Compare that to the gametocytes of all of the other species, which are round to oval. And you could see just a little bit of a remnant of the rest of this red blood cell here. I actually like this next picture because it's even more definitive, where you could see that the gametocyte is within this red blood cell, and you could just see the little rim of what's left of the red blood cell. So these are intra-erythrocytic parasites, even though they sometimes look like they're just hanging out in between the red blood cells. So that was Plasmodium falciparum. Let's move on to Plasmodium malariae. So in general, it is a larger trophozoite stage. So it's still about a third the size of the red blood cell, but it's a little thicker than Plasmodium falciparum. But then more importantly, all stages are present with all of the other species. It's only Plasmodium falciparum where we tend to just see thin, delicate rings and then maybe some gametocytes. All the other stages, though, you very commonly see late-stage trophozoites and schizonts. Some late-stage trophozoites with Plasmodium malariae include what we call a basket form. See how it's a thicker ring, but it has this vacuole, so some people think it looks like a little Easter basket. Also, classically, the band forms where the late-stage trophozoite extends from one side of the red cell to the other. There's also the schizont stage, which is notable for having just a few merozoites, usually 8 to 10, and then a central ball of that golden hemozoin pigment. Okay, let's move on to the other side of the algorithm, Plasmodium vivax. Plasmodium vivax is known for its amoeboid trophozoites. It's larger. The infected red cells are large, and it is larger. It is greater than a third of the size of the red blood cell. The schizont has a lot of merozoites, greater than 12, up to 24. And as with all the others, all stages are present. So here are some forms of Plasmodium vivax. Notice the amoeboid chromatin. What they mean by that is there is these amoeboid-like processes that go off into different directions. It's like an amoeba. Also, something that Plasmodium vivax does is it alters the membrane flexibility of the infected cell. And so you see this phenomenon where it molds to the red blood cells around it, which I call hugging. And I remember this by thinking that Plasmodium vivax is very vivacious. It likes to go out and hug the red cells around it. And it also likes to go off in all these different directions like a big amoeba. So that's vivacious vivax. Last but not least is Plasmodium ovale. Also has an enlarged red cell, often looks a lot like Plasmodium vivax. Sometimes it's very difficult to tell the two apart, but it tends to be more compact than Plasmodium vivax, less amoeboid. It's still relatively large, and then a third of the infected red blood cells take on an oval shape. Also, these oval-shaped cells often have jaggedy edges, which are called fimbriated. So here's some nice examples of oval-shaped red blood cells with fimbriated edges. And then you could see the stippling. And then the trophozoite inside is a little hard to appreciate, but often it's more compact than Plasmodium vivax. Sometimes we can't tell them apart, and then we just say Plasmodium vivax / ovale, since the treatment is very similar for the two. Now, last but not least, if we're talking zoonotic parasites, we also have to consider Plasmodium knowlesi. You're only going to see this in patients that have gone into rural, like jungle areas of Southeast Asia. And in that case, the parasite looks like Plasmodium malariae with these very nice band forms, but it acts like Plasmodium falciparum with very high levels of parasitemia. So that's something that you may encounter depending on where you're practicing. With all of this, on your peripheral blood films, you want to calculate the percentage of parasitized cells. You can calculate this off the thick film or the thin film. There's a number of formulas. The most exact way is to count in one high-powered field how many infected cells there are, and then how many total cells there are, and then you just do a percentage of infected divided by total times 100, and then you do that over multiple high-powered fields, and you average it out to get an idea of what your percent parasitemia is. Now, when you're doing this, you only count the asexual stages. You do not count the gametocytes. That's because the gametocytes are not infectious to humans. It can be operator dependent. It is subjective. You want to make sure you're counting in the right area of the film. And so it's best to monitor if you can by having the same person perform the red blood cell counts. You're going to get more standardized results that way. Now, the percent parasitemia is used to determine appropriate therapy and to monitor response to treatment. There was a time when percent parasitemia of 10% or higher would lead to a recommendation to perform apheresis to remove with red cell apheresis, the infected cells. The CDC no longer recommends that, but the American Association of Apheresis says that it's still a viable therapy. So I think it's a tool that you can consider if you have it available at your center for someone who's very sick with a high percent parasitemia. All right, now that's all great. We're talking about malaria, but what else can we find on a blood film? So I'll let you think to yourself for a second or so. All right, so we talked about Plasmodium species. We cannot forget about Babesia species, especially in the Northern Hemisphere, North America and Europe and Asia. We have Babesia species, look a lot like Plasmodium species. We also have the extracellular trypanosomes, specifically Trypanosoma brucei and Trypanosoma cruzi, depending on where you are. Those are the primary trypanosomes that you can see in humans. And then the microfilariae, which are multicellular worms. Then less commonly, you can see some other things such as Ehrlichia anaplasma morieli. These are bacteria that infect white blood cells. You can see intracellular yeast like histoplasma, and you can even see spirochetes of Borrelia, specifically the relapsing fever Borrelia, like Borrelia recurrensis and Borrelia hermsii. So you have to keep an eye out for a number of different things. Don't just think about malaria when you're looking at your blood film. Now, I created a little bench guide that is available through the College of American Pathologists. And this happens to be one of the images I took showing the size difference of these main parasites, just to give you an idea of how they differ in size. So, a microfilaria is a multicellular worm, relatively large, at least 100 red cells in length, compared to a trypanosome, which is a protozoan parasite, looks a bit worm-like, but is really only about 3 red blood cells in length. And then you have your different types of Plasmodium species. So here's the book if you're interested. I make no money off of this whatsoever. I volunteered my time, and it's available through CAP, which is a nonprofit organization. There's an electronic version, or you could buy a nice, durable, laminated version that really holds up well. We've had them in the lab for years, and they're still in just as good of shape as when we bought them. There's also nice laminated cards that you can get through the World Health Organization, benchtop guides. And if you're in a resource limited area, I believe you can get them at either a discounted cost or no cost at all. All right, so let's talk about some of the other things you can find. Babesia species, it's a protozoan parasite related to Plasmodium species and other apicomplexa parasites. Babesia microtes, the one that we worry the most about in the US, and it's found mostly in the Northeast and the upper Midwest. But then we have this other species, Babesia duncani, you can find on the West Coast. And then we occasionally see this Babesia divergens-like strain. And Babesia divergens happens to be the strain that we see in Europe. So in North America, and specifically the United States, we have the hot spots of the upper Midwest, the Northeast, and then some scattered cases around the West Coast. Now, you can imagine having a patient, perhaps in, say, Connecticut, who just returned from Africa, but also happens to be in an endemic area for babesiosis, and it may be very challenging to tell the two apart. Here's some nice examples to show you. This is what Babesia looks like on a thick blood film. Looks just like Plasmodium species, except for the fact that there's a little bit more size variability. But you see that little dot in that little ring-like stage. And then here are the ring forms you see on peripheral blood smear. So let's go over how you tell them apart. First of all, the similarities with Plasmodium falciparum and Babesia, the size of the infected red blood cell is normal compared to uninfected neighboring cells. You mostly see rings, those early trophozoite stages, and often there are no red blood cell inclusions, although sometimes you can see Mauer's clefts in Plasmodium falciparum. So those are the things that make them look similar. How do you differentiate them? Well, if you see banana-shaped gametocytes, it's Plasmodium falciparum. That's easy. The gametocytes of Babesia just look like all the other stages of Babesia. They all look like rings. Also, Babesia is more likely to have very pleomorphic rings. And if you see a Maltese cross, that is considered diagnostic and classic for Babesia species. It also more commonly has extracellular forms. Now, I have to say that in the parasitology laboratory, the thing we see the most often is the pleomorphism of size and shape. This is a case of babesiosis. You can see small rings, larger rings, rings that look like they have little things coming off of them. This one looks a bit like a tennis racket. Very small oval-shaped parasites. Um, Now, if you see again that Maltese cross, that's great, but in actual clinical practice, it's hardly ever seen. And then nice extracellular parasites tend to be pretty common with Babesia. Okay, moving on to the trypanosomes, we have T. brucei and T. krusei as the two main ones. And do any of you know the main morphologic feature for differentiating them? So the answer is the kinetoplast. The size of the kinetoplast is most important for differentiating them. In T. brucei, it's small. In T. krusei, it's large. Now, in Trypanosoma krusei, often they form a C shape, but that's less reliable. Sometimes these guys form a C shape as well. So really, it's the size of the kinetoplast that's most important. Microfilariae. I'm not going to get into all the different ways to tell the microfilariae apart. It's rather complicated. First, you have to find them, and that is why when you're looking for malaria, you first scan the entire slide at low power using just the 10x objective, because you're looking for these guys here, the microfilariae. And if you're wondering, the little purple dots are white blood cells. So if you just went down to this area and went right down to 100x, you could miss them altogether. So you screen the entire slide at 10x, including the feathered edge on the thin film and the thicker areas. And then once you found them, you look for certain identifiable features like the head, the tail, the internal nuclei, whether they go to the tip of the tail or not, and then the presence of a sheath. And the sheath sometimes just appears as this negative outline. So it can be a little challenging to find. So we've talked about all of the different parasites to some extent in blood, but now let's go away from morphology and talk about other diagnostic methods for malaria. And we'll start with the rapid antigen tests because they're so important now and they're so widespread. So these are rapid. They're usually performed in about 15 minutes. Easy to perform. Any of us could read the instructions. In fact, many of us have now performed at-home COVID tests, which are nearly identical. There are many on the market worldwide, and unfortunately, only one of them has been approved for use by the FDA in the United States. That's the Binax Now malaria test, which is pretty good, although it's probably not the best that's on the market, but we can't get the others, and it's pretty good for our needs. Now, many of them are very suitable for endemic settings. A lot of them are very stable at high humidity and high temperatures and very easy to use. So that's why the World Health Organization has put so much emphasis on using these tests, especially because microscopy, as we said, requires a good microscope, a reliable power supply, a skilled worker who is very familiar with malaria, and then a way of keeping that worker competent so that the skills don't drift over time. Those are often things that are a bit of a challenge in a resource limited setting. So if you are in one of these settings where they're using one of the many rapid diagnostic lateral flow assays that are available, you should go to this particular publication or the World Health Organization's online materials where they've reviewed most of the commercially available tests. They're not all created equal. Some are very sensitive, some are less sensitive, some have a lot of false positives, some have a lot of indeterminate results. And this review and the ones previous really cover all of those differences. So wherever you are, look up the test that you're using so you understand how good it is. Now, these different RDTs target different antigens, but in general, there are three main antigens that are targeted. There's the HRP2, histidine-rich protein, that's specific to Plasmodium falciparum, and it will last for up to 43 days after treatment. These other two, well, let's start with Plasmodium parasite lactate dehydrogenase. This can be species specific. There's a species specific one for Plasmodium falciparum and one for Vivax, but there could also be one that is just it detects all species. Now, this is an interesting target because it only is found with viable organisms and it doesn't persist. So you could actually use this to monitor for successful follow-up after treatment. Aldolase also does not show persistence after treatment, and aldolase is only a Plasmodium genus level marker. It's not species specific. So let's look at the Binax Now. The Binax Now uses two of those antigens. It uses a specific band, T1, that's impregnated with this Plasmodium falciparum histidine-rich protein 2. So T1 is specific for Plasmodium falciparum, whereas T2 contains aldolase, which is found in all Plasmodium species. So if you have all three bands, your control band and these two, you have Plasmodium falciparum or potentially a mixed infection. If you only have the top two with your T1 band, then this is Plasmodium falciparum. If you have the T2 band and not the T1 band, it is one of the species other than Plasmodium falciparum. And then if you have just the control band, it's negative. If you do not have the control band, then it did not work and you have to discard the result and try to get a new test. So how would you use the Binax rapid detection method? Well, it's very good for initial screening, but it doesn't replace conventional slides. It has a sensitivity for Plasmodium falciparum of about 88 to 99%, but it will miss maybe 1 out of 10 Plasmodium falciparum cases at lower parasitemia. And of course, those cases can become high parasitemia very quickly. So you always have to follow up with thick and thin blood films, regardless of the result of the Binax Now. And then you also have to do a calculation of percent parasitemia. You could also use it to confirm your diagnosis. If you're trying to differentiate between malaria and babesiosis and you see a lot of parasites, a positive result is helpful. If it's negative, then maybe it's babesiosis. It could be helpful trying to differentiate malaria versus artifact if you're not really sure if there are parasites present. But again, you always have to do blood films as a definitive confirmatory test. And that's the way the test was approved by the FDA in the US. Now, other limitations, there are parasites that lack the histidine-rich protein 2 and sometimes 3 as well. And if you lack that, you are going to miss Plasmodium falciparum and you get false negative reactions. You should still have a positive aldolase, though. So you'll have a positive result, but you'll miss that it's Plasmodium falciparum, which could be important for treatment. You could also see false positives with any lateral flow assay. Patients with rheumatoid factor, sometimes other parasitic infections can cross-react. And then very rarely, there is something called the prozone phenomenon, sometimes called the hook effect, where a positive that is so high, that has so many parasites, can actually overload the system and the antibodies never bind and produce a band that you can identify. So you get a false negative. And I'm sorry, this should say false negative result. And so a false negative result with prozone is very worrisome because then that could be a patient that has a very high level of parasitemia and you don't want to miss that. So this is why you have to confirm all of your tests. It also is not reliable for semi-quantification. The line intensity only correlates somewhat with how many parasites are present. Now, what about PCR, you may be asking, or other molecular methods like LAMP? Well, they could be very useful. They're often highly sensitive. They could be used for initial testing if you can perform them rapidly. And remember, malaria has to be performed on a stat basis. Unfortunately, many parasitology labs don't offer this test at all. If they do, they're probably a larger center, and they often will batch the tests. So they're running them only at certain times of the day, maybe only on certain days. So that's not appropriate for care. So then it really is more of a confirmatory test. And then also don't forget that you still need to calculate the percent parasitemia from the thin or sometimes the thick blood film. So instead, confirmation of a diagnosis is a common way to use this. Again, differentiating between malaria and babesia or malaria versus artifact. You could also detect patients that have very low levels of parasitemia, even lower than what can be detected by blood film. So if you're in an area where you're aiming for elimination and you want to detect every single last case with parasites, then PCR may be implemented. There are several commercially available assays. In the United States, unfortunately, none of them are FDA approved or cleared, though. So you would have to validate the test in the laboratory as a lab developed test. As I mentioned, there's also a LAMP test. And for our colleagues that are practicing in Canada or Europe or abroad, it's available and very good, but it is not available as a FDA approved test in the United States. So, in conclusion, I just gave you a lot of information, and here are the highlights. Malaria is a potentially life threatening disease. Laboratory diagnosis should be performed on a stat basis. Your thick and thin blood films are the gold standard for diagnosis, even to this day. Thick films are best for screening, whereas thin films are best for species identification. Remember, don't use the word speciation incorrectly. And antigen detection is also rapid and can be used for the initial diagnosis, but needs to be confirmed by slide examination. PCR could be useful as an ancillary test or as a primary test if it can be performed rapidly. So, with that, I will leave you with this lovely picture of these cookies made by one of my really talented laboratory technologists, Emily Fernholz. She made these for World Malaria Day. I'll let you figure out if you could diagnose the species from all of them. I see a beautiful Plasmodium malariae here in a small cell with a central pigment and just a few merozoites. So, with that, I will finish, and I hope that you found this helpful. Thank you for joining me today.